clearly, I think it's unequivocal that access will be challenged in many dimensions moving forward. What can we do broadly in the context of declining resources to figure out targeted interventions and programs that can help mitigate that gap?
Welcome to Rural Health Today. I'm J.J. Hodshire, President and Chief Executive Officer of Hillsdale Hospital, and this is a podcast where we connect you, the listener, to what really matters the most in rural health. Our guest today is Dr. Mark Holmes, academic leader and health policy researcher at UNC Gillings School of Global Public Health. Welcome to the show. It's great to have you, Dr. Holmes.
Thanks, JJ. I'm delighted to be back.
Why don't you tell us a little bit about your background, your role at UNC, how long you've been there, what brought you to the organization, and why in the world? Why'd you get into this? Why this field?
Yeah, so I grew up in Michigan and went to get my graduate work in North Carolina and arrived here in Chapel Hill at UNC in 1995. And I got my ID, and they never have managed to take it away from me. So they haven't.
Hasn't been revoked.
Yeah, it hasn't been revoked. So I was a graduate student here, and then have joined different research programs over the years, and am now faculty. And in terms of the field, I fell into rural health by happenstance. I was trying to figure out what my dissertation was. My advisor called me and said, "Hey, I've got a topic and maybe some data." And I said, yeah, I could do rural health, and didn't really think a lot about it. Didn't know it existed really, like I think a lot of people. I grew up in rural Michigan, as I've mentioned to you before. Mm-hmm. And so that combination of that, having that background, it was a great match for my skills and interests. And really what draws me to it and keeps me here more than anything is that rural health is a place where policy matters. And it's a situation, it's where I feel like I can make a difference. And so it's exciting to be able to work on something that's policy relevant.
Yeah, not only are you, looking at policy development and research, but you also teach, correct?
I do teach, yeah. And so it's great to inspire those as well. Yeah. And I'll tell you that the last 5 years, I've definitely seen an increase in people who are interested in working in rural health. So
see, that was going to be my next question. Oh. So you're starting to see a surgence of, interest in rural health?
Absolutely. 5 years ago or 10 years ago, I would have to recruit people and students and say, hey, you want to work on this project? And many of them weren't from rural areas or never really thought about rural as a career. And now there's usually 5 or 6 outside my door every August. Hey, I'm super excited about rural. What can I do? And not all of them are from rural areas. Some of them are from urban, and just know that this is a place, a field where they can make a difference, and that's where they want their career to be.
So what would you identify as the shift in that mentality? Do you think there's been an awareness, a better job at that? What would prompt a student to come in? 10 years ago, they weren't. Now they may be. Do you have any insight into maybe what has happened?
That's a great question. I would say it probably is the increased awareness of what rural America is going through from a healthcare standpoint, from a health standpoint. It's certainly in the media much more often now. I think I'll get an Uber from the airport in Washington, and someone will talk to me about rural hospital closures, just kind of throwing that out there. That is, it has really entered the conversation, I think, nationally.
Yeah, it's certainly been elevated, that's for sure. And it's most concerning because we know that rural hospitals historically, traditionally, are the economic engines, number 1 or 2 employer in their respective community. So goes your community hospital. So goes a portion of your community, your economics. So I think the awareness level is definitely out there. Great job to you for making that known to students who may be achieving to become administrators or healthcare professionals, that there is a segment of our population that really needs help right now, and that is rural residents in rural communities. And in Michigan alone, I just was reading yesterday, 20% of our state is identified as rural. Millions of Americans are identified as rural. And so for us, it's a passion, and for you, it's an awareness that you get to bring to students. So thank you Dr. Holmes, for doing that. I mean, obviously, it's a niche passion. It's not like everybody is standing on the street corner, but we really appreciate your advocacy. It is obviously making a difference even in one small portion of the world in North Carolina. So thank you.
Well, I do think it's important to recognize that podcasts like this, I think, are also important in getting the word out and helping to make sure that it remains on the mind of the collective media across the country. And it's not just, to your point, I would say 10 years ago it was a niche kind of concern, and you might read about it in local newspapers. But when Washington Post and New York Times are talking about it, then it's clearly a national issue that's getting attention.
Absolutely. And I think probably, and we'll talk a little bit about this, but certainly it's going to be heavy on the minds of congressional leaders. It's going to be part of our midterm discussion, I believe. I firmly believe that. It's going to be part of, election discussions and presidential elections in the years ahead. But we'll get into that in just a minute. So for someone, Dr. Holmes, who may not know you, right? Here you are. You're from Michigan. You live in North Carolina, correct? And so can you tell us an interesting or fun fact about yourself, kind of to relate you to our listeners? Like, this guy is real.
So, great question. I think I probably would describe myself as a recovering casually competitive sailor. And so let me talk about that. Growing up in the Thumb, we were 30 to 45 minutes from Saginaw Bay. And so my family had a sailboat for, probably age 6 to about 16. Wow. And for a couple of those years, we did the competitive sailing. There's a league out of Bay City. And so we did that, and it kind of culminated with the Port Huron, the Mackinac race. And
that's awesome.
Which was a real great experience. I remember, turning the buoy at the turn there, way up there at the northern end of Lake Huron. Oh yeah, we did it in the middle of the night. It was a clear night, and you could see every star, and it felt like they were right there. It was really magical for that. So yeah. Yeah.
Well, congratulations. Now, if you tried it right now, it's a little chilly out there. So obviously a lot of sleds out there and some ice fishermen, but the Great Lakes, how amazing, how incredible. So it's great to have a Michigander on this podcast. We don't get that much. So thank you for connecting with us. To advocate for rural health, leaders in healthcare need to understand the ins and the outs of how our field is influenced by changes to policy and to payment models. We'll ask about all of these changes that are going on right now in our country, Medicaid, health access, and of course, what all of this has to do with rural health. Dr. Holmes, what has been your primary focus on health research lately? Where have you focused most of your attention? And then a follow-up question to that is, what do you see as the most important to the academic field of healthcare right now?
Well, my primary focus since July 4th has been the Rural Health Transformation Program. And that was part of H.R. 1, as I think all your listeners know, and the funds have started to flow as CMS made their awards at the end of December. And so we've been looking at everything from what do we think is going to happen and putting out data in terms of, based on these 7 rural factors, how do we think the states line up, shaking out how the funding looked, how does it correlate with different aspects. And so really trying to understand what's behind and what's happening with our HTP. Mm-hmm. And there have been, I think, a lot of people across the country who are very interested in that to really see this. I mean, it is a, I don't find it hyperbole to say it's a generational opportunity. I think for years we've recognized that rural communities are just got one hand tied behind their back. And every time we've talked about, we need a little more financing for this, that, and the other thing. And it's been stuck in the paradigm of these are the pathways by which we can inject resources into rural. Mm-hmm. We can change Medicare payment policy. We can do something with Medicaid. And the program represents the flexibility for states to look at what what's going on in their state and say, this is our top need. This is what we think is going to make a difference. So the $50 billion that's going to rural America is very exciting. I'm also as excited about what we're going to learn from 50 different experiments and seeing as Wisconsin deploys their program And Kansas has their new approach, and Georgia tries this. Can they learn from each other? Can we find, the breakthrough ideas that come out of this laboratory, for lack of a better term, or policy laboratory at least, and apply those lessons going beyond so we can get those sustainable changes that really are necessary?
Great answer. If I have permission to give you some information from Michigan that maybe you could include in your research. So just a historical overview of what has happened. So Congress takes away basically $1 trillion from us under the One Big Beautiful Bill. They give back $50 billion to be divided. We didn't know if it was equally, by application that has merit, by politics. We didn't know. And all of the hospitals started scrambling, right? Michigan, actually, the Michigan Hospital Association commissioned a task force. I chaired that task force. That we would then make recommendations to the governor or her designee, and she chose Michigan Department of Health and Human Services to actually spearhead the project. But we spent about 4 months as a committee, representative of all rural hospital CEOs, critical access, rural, mid-size vital hospitals, and systems with rural hospitals, came together 4 months, put our proposal in to the Michigan Department of Health and Human Services for things that we as rural hospitals need. Not one recommendation was accepted. Michigan's application is forwarded to the federal government, CMS review. We are the 7th lowest achiever of the grant in all states, and we received $173 million for the state of Michigan over 5 years. Now, I only say that because as you do your research, you can maybe understand from our perspective the concerns that we have. Michigan Department of Health and Human Services put out a application that we had to FOIA, which we did through our senator's office. They didn't share that application with us. And now we're finding out, and there's testimony happening last week. You can even see it online at the Michigan Senate and State House, where there's a lot of questions about how that funding is going to be distributed and used. What defines rural, right? I think there's going to be a lot of questions about that. What did states identify as rural? Is it a big system of a hospital that just owns one rural hospital so they get a disproportionate share of funding? A lot of concerns, but among those, are that in the state of Michigan, theirs is program based, and hospitals have to initiate programs. It's not for equipment. We know that the president and Dr. Oz already made it clear that it cannot be used for any type of supplanting of funds that they cut out under the One Big Beautiful Bill. But, I guess my question to you is, are you hearing any of this, like Michigan's facing, where no recommendations are accepted by rural hospitals? They want to turn into programs that are going to create legacy costs. Do you think that that's going to be, is it going to be played out in congressional hearings? Is it going to be played out in state hearings? What are your thoughts? Because I can tell you from a guy sitting at the rule table that we are very unhappy with the fact that we weren't represented.
So let's, JJ, you raise a number of critical points, and let's start with the beginning, and that is some estimates, the most credible estimates I've seen are that over the next 10 years, HR 1 is taking $136 billion out of rural hospitals. Yep. I think it's hospitals. And the RHTP is at $50 billion is less than half of that. So we need to start with that idea. I've been trying to separate those two concepts and say, good, the HR 1 is sort of doing its thing, and that's that. Let's focus on RHTP and view this as how I think we should, which is a short run. Now, 4.5 years left on the runway to make sustainable changes. That's a tall order, and $50 billion sounds like a lot, but compared to the needs, it's going to go fast. Part of the challenge of the timeline of this that was passed by Congress on the July 4th was having the money out the door by December 31. And once you start building in what a grant or the grant application process looks like in review and negotiation, states had 51 days to prepare their application from the time it hit the street to sending it in. Mm-hmm. That's really fast to write what is essentially a $1 billion plan. States were instructed to write $200 million for 5 years. So part of that was this I guess my a little bit positive idea on it was that people had to be creative and move quickly and come up with ideas. And would they have done things differently with another 2 months to think about it? Almost certainly. I think that I don't know that a lot of states said, wow, we got done with 3 weeks to spare. So CMS has made it clear that the expectations are that what you propose and was accepted and awarded on December 29th is your initiatives for the next 4.5 years. I am hopeful and optimistic that CMS will use CMS has a number of provisions in their grant mechanism, cooperative agreement, to hold the states accountable. And are they meeting their milestones? The policy actions that they propose, are they hitting those? And so every year there's going to be some reallocation of funds, which I think is expected as states hit their milestones or don't. And then there's that clawback and accountability provision. I am hopeful and optimistic that CMS is going to recognize that after a year or two, we're going to learn about things that are working and things that are not, and allowing states to say, all right, North Carolina, you proposed policy A or initiative A, and Michigan is doing something similar, but they're doing initiative B with this twist to it, and it looks like it's really working well. North Carolina, you can adjust and stay within the same theme, but sort of react to that. We don't know how that's exactly going to work, but I think that everyone recognizes that that's going to be a tension going forward, is not allowing the states to be too flexible and change what they propose, but also recognizing that we're going to learn a lot in the first 18 months about what's happening and what's not. I think I'll finish with the notion of a general malaise, I think, among hospitals specifically and healthcare providers more generally, and concern, wariness that these funds will actually be allocated in ways that will help them. And I think there was initially in July and August in particular a lot of concern of where these funds would be going.
Right.
As I'm reviewing the summaries that have been made public, I think, overall, I would say most states are doing things that are rural centric and making good faith estimates to improve rural health. Will there be some states that maybe could think about better allocating in the future? Perhaps, almost certainly. But hopefully that will be they'll have the flexibility to learn from that as they're moving forward.
Well, you know health policy much better than I do. So let me ask you this question regarding this particular grant or allocation of funding from Congress. Is this canonized, or could the midterms impact this? Could the next presidential election, if there's an administration change, could that impact some of this, or is this already out? Is this done? Is this happening for the next 5 years, no matter what happens in Washington?
So I can't speak to politics, but I can speak to policy.
Right.
And that is, sure enough, any program can be started or stopped by an administration, or Congress can choose to defund it. So that's a possibility. I think I just said I wouldn't speak to politics, but I do think that this is a pretty popular program. And so I'm actually more concerned about another direction, and that is a sentiment of we just sent $50 billion to rural America. Why do we have these other programs? We should be revisiting those and thinking about, are these still doing the things we want? And I think if we have a situation where we have the RHTP and that's shiny and everyone's looking at that, and on the with the right hand and on the left hand, we're taking out things that have been longstanding legacy funding programs that we know have been successful. That would not be an ideal situation to move forward. So we got to be really mindful that we're not supplanting and growing content, if you will, with legacy programs.
Yeah, agree. The last point I'll make on this is, unfortunately, right now, congressional leaders are going around in an effort, in my opinion, to minimize the impact of the One Big Beautiful Bill, H.R. 1. They are saying things like, our own congressman has made this comment, things such as, this program will help save rural hospitals. I don't believe that. I really don't. This is not going to generate additional revenue. This may help us look at reduced costs through programs, but does it include technology? Some do, some don't. I just have to say that I think we have to be very mindful that some of that rhetoric is that, hospitals should be doing just fine because of this. To the original point that you made, to carve out, hundreds of millions of dollars, and then we thought that was it. But then to carve out billions of dollars from healthcare. I mean, we thought we were just going to stay with millions. No one would have ever in our industry thought that it would get to the level that it did under this H.R. 1, is that, carving out that much money and giving us back 30 or 40%, it's really not supplanting it. And to your point, I think it's important for our listeners to understand we should look at this from two different viewpoints. You can't look at the Rural Transformation Fund as supplanting what they did in H.R. 1 because they're two different tracks. They're two different programs. We still have to address what they did in H.R. 1. That'll be for another show, Dr. Holmes. But to the point of the rural health transformation, I'd love to have you back on again, maybe in 6 months to a year on this particular topic to see, what is happening in our states with this funding. So that'll be my challenge to you, if I could, in the next year or so.
Jay, I mean, what an insightful comment, JJ, because there's a lot happening in the next couple of years in rural health, in hospitals in particular. We've got RHTP, which is injecting funds that some of which are finding their way to maybe not directly benefiting hospitals, but really helping with some costs, for example, or maybe some technical assistance or conversion to new payment models, et cetera. Mm-hmm. On top of and you have other things that are happening there. And so, for example, if there are moves to make the rural population healthier, that keeps people out of the emergency department, and that helps with costs from that standpoint. So there are some of, I don't want to suggest that RHTP is not going to benefit hospitals, but it's certainly not going to be to the tune of $50 billion. Mm-hmm. Meanwhile, you have the H.R. 1 provisions, some of which have already been enacted, most of which will be really starting to come into play next January. And how long will it take for those provisions to start really changing what we see in rural hospitals? And so it's gonna be really hard to monitor what's happening over the next couple of years and understanding how these things interplay with each other.
Yeah, I agree. Well, we'll say this, to be continued on that issue, and we'll get you back for that. Well, let's transition to some other, I say exciting. Some people might say this is a boring world you live, JJ. But Dr. Holmes, why don't you tell us about value-based payment models, how they work, how hospitals should expect those models to change over the next few years, because they will. Could you give us some insight into that?
So we've long known that one problem with our healthcare system is that it pays for sickness. And so if you really, money transitions when someone needs healthcare. And so this has created challenges, and I'm an economist by training, and so incentive problems. And so instead, value-based payment at its core really looks at switching to the other way, and that is let's pay for health. And some models will actually pay for healthy people, and the incentives come out that way. But most of them are designed to create the incentives so that people are not getting that health care. Are not needing that health care would be a better way to say it. Yeah. So that might be, let's make sure that they're getting their preventive services and getting their A1C down below 7. Let's make sure that they're getting their mammogram on a timely basis. And so if we catch something, it's early stage rather than waiting too long. Or it may be, let's disincentivize care that we think is expensive. Emergency department is often one of the most expensive settings to treat conditions. Instead, if we could find ways to manage them in the primary care setting. So keep your diabetes under control so you don't have to be admitted. There are people being admitted because of a dental issue, a cavity that you've ignored for months and has really become infected. So value-based payment pushes that upstream and brings the provider, whether that's the hospital or the physician or the clinic or the payer, into the same incentive structure as the purchaser, so that together they say, we want to deliver a a healthcare system that keeps our population healthy and our costs down. And that's a two sort of, you can do both of those. And that's a change in how healthcare is paid for. Mm-hmm. A lot of excitement about VBPs. A lot of payers are moving that direction, and they're working with providers to do that. And that's where contracts are. Most payers, insurance and public payers like Medicare and Medicaid, have some sort of goal of we want to have X percent of our covered lives under some sort of value-based payment system. The challenge often with that, and particularly acute with rural, is there comes a time when you pick your metaphor, you jump the canyon, you got 1 foot on the dock and 1 foot on the boat, and it's separating, where you're in both worlds, and that makes it really hard. And usually what that leaves is the provider in a period where considerable, if not substantial, negative finances, while they're under this incentive to keep people out, to keep people to not being paid for delivering healthcare, and sometimes penalized for healthcare, but the investments to keep people healthy have not paid off yet.
Right.
As an example, we know that with someone with diabetes, if they're above an A1C of 9%, for example, it takes about 18 months to have those investments and the change in the way that healthcare is delivered to lead to downstream improvement in health and cost. So that's a challenge. And again, coming back to rural, in particular in rural providers who don't always have the cash to finance that valley of despair, whatever, again, another metaphor you want to pick, as you're undergoing that transition.
Yeah, what a great analogy. I was just looking at some data. I had a presentation yesterday in Detroit, and I was looking at some data from my own hospital. And to your point, just giving the example of dental, right? We do not have enough and adequate coverage for our patients in this community for dental care. Medicaid does not cover very well, and so what we end up with is a population either on Medicaid or no-Caid, because we still have a lot of folks like that who still don't have insurance. Anyway, looking at some of my own ER data, how alarming it is to look at the number of patients coming in because of dental pain and abscess. To your point, ER is the highest cost point in the healthcare system right now, the highest cost point. Inpatient is second, but ER, to get an ER bill, which if you don't have insurance, you're coming to the ER, because under EMTALA, we have to serve all the patients. And so you come in with a toothache, and some are significant. I've seen horrific and heard horrific stories about it. But anyway, to your point, if we look at it from a different lens, though, taking care of those patients where they're incentivized on the front end with preventative care, I think that is so important. I hope, Dr. Holmes, that we can get to that one day. But the other area that we focus on, so that's one area, right? The other area that we focus on, we heard a lot about it, started to rise about 10 years ago. It's this thing called social determinants of health. I went to my first conference about 10 years ago at Becker's, and I heard about, the speaker was getting up talking about SDOH. I'm like, it's another acronym for hospitals and healthcare to worry about. But to fully understand social determinants of health is really to understand an important concept. So you've studied it, you've researched it, you've looked at it, it's all part of what you do. I'm going to ask you this question: how should hospitals be approaching social determinants of health? And, obviously now we're facing these major Medicaid cuts starting in 27, 28, all the way up through 32. We're going to claw back the average commercial rate from most states. Hospitals are going to start losing money from Medicaid patients again, when some just received most recently enough to cover their costs. Long story short, there's this whole concept of SDOH. Can you talk to us about, how hospitals should be approaching this concept? And then what's going to happen with payment? Is it going to follow?
So I'll bury the lead a little bit, but tell a little bit story and a little background and context on SDOHs for your listeners who may be less familiar with it. Our former Secretary of Health and Human Services here in North Carolina liked to tell a story from back when she was a resident. and she was in the emergency department or maybe a hospital outpatient clinic, and she saw this graduate student, probably weekly, maybe every 2 weeks, like 3 or 4 times, and she ran blood panels, and she was losing weight, her hair was falling out, her eyes were kind of sunken, and ran blood panels and tests and all these different things, couldn't figure out what's going on, and went to her attending and is like, I don't really know exactly what's going on here. And the attending walked in and in about 10 seconds said, so tell me where you're sleeping. And the student said, well, I've stayed at my friend's for 2 weeks on her couch, and then I had, she had to leave, and so I went over here for 10 days, and then I was over here, and then I got a hotel room for a night, and this was someone who was, housing insecure and didn't, we would call, she's homeless. She just was able to patch it together with friends and colleagues. And once they figured that out, they were able to say, let's put you over here, let's get you these resources, and her health, returned right around. And there's two reasons that story is a great illustration of what we're talking about. One is how powerful these upstream factors are in changing medical outcomes. And whether it's the story here or a child with asthma who lives in a house with the carpet that's threadbare and is creating all kinds of air quality issues, or someone who's food insecure and is giving all their food to their children, and so then the only way that they can do it is they eat the donuts they have at work or something like I don't know, but there's all these upstream elements that can really lead to medical care. And the second is how hard it's been for healthcare professionals to recognize those, partly because that's not how they're trained in a medical framework, and we've started changing that in the way that it gets, but probably more importantly, it's been considered outside the scope of their work. There's no way to sort of see what's happening. There's no way to, it's limited in terms of the ability to actually do something about it. And fundamentally, it generally has not been paid for. So now we're back in a situation like we just talked about value-based payment. You have providers trying to understand, I know I can do this. I know that it will make this person healthier, but not only is it going to cost me money, but if it works, they're not going to come to the hospital anymore. Right. And with all their extra money that healthcare providers, particularly rural hospitals, have right now, and the air quotes lots don't come through the
beautiful.
But that's I think we're the last few years we've really started to recognize how important this is, and it's everything from analyses that have determined what percent of a person's health is determined by medical care versus genetics versus the environment, which means where you live, where you work, what you and how, those kinds of things, and how important these social determinants are. Yeah. And we're at a place where no one's really sure. We know what to do, but no one can really figure out how to pay for it. And that's frustrating. Yeah, in North Carolina, our Medicaid waiver had a Healthy Opportunities pilot program, which exactly did this, and it connected in regions of the state. It connected healthcare providers and gave them a tool to refer them to their social needs. And analyses have found that cut medical care costs as we would have expected. Yeah. And so we know that this is important. How are we going to pay for it in the future, especially as we're talking about Medicaid and other cuts, Medicare and Marketplace, and need to be said as well that those enrollments or payments are both going to go down. It's unclear how it's likely that we're going to slide backwards in our understanding and our ability to manage social determinants.
I think you're right. I know you're right. I mean, obviously, you're the researcher. You've looked at it. I think if we were to look at, down the road, one of the most important forms that I feel we utilize in the clinics is an SDOH form. And we're asking questions now of patients when they come in. Could you pay your rent last month? Did you pay your light bill last month? Did you have food every day? Do you have access to transportation? These are all things and factors that impact an individual's physical or mental well-being. And I think at a minimum, it's raised such an awareness in the minds of administrators that it is critically important to ask those questions, because if we can get to the basis of that problem, we can stop the downstream utilization of ERs, hospitalization, readmission rates. I mean, all of that would be wonderful. And how many CEOs 20 years ago would have said, we don't want patients in our hospital? But that's what we say
Right.
now. It's not appropriate. The shift from inpatient to outpatient, from volume to value is so important in our industry right now in order to contain costs, but also at the end of the day, it's what's right for the patient. And I think we lose perspective of that at times. So what's right for the patient? Let's talk about that, because access to healthcare and healthcare scarcity is heavy on the minds of countries outside of the United States, right? If you go in the United States, you see, on every corner, Walgreens is giving vaccinations for flu shots. You got prompt care, urgent cares, hospitals now super competing with each other. Billboards going up. Our ER wait time is 2 minutes. Ours is 1 minute. Ours is we get you at the door. I mean, all of these things are happening, but access is still, we're still hearing that access is a problem. To get into primary care, it's difficult because in rural communities, they can't recruit physicians into primary care. And so there is months of waiting. So let's address the issue of healthcare access, if we could. From your research, what you've done, what you see, where are we at today, and what do you forecast into the future with healthcare access?
Wow. You ask questions that take about 4 hours to respond to, but I'll do my best.
Yeah, 2 minutes.
I think, first off, I'd say that access is multifactorial. And so it's everything from availability, how close am I to the local provider? So to your point there, is there a primary care physician nearby? Am I able to get there? And so, 8 to 5, Monday to Friday doesn't work for everyone. Do I have a car? Do I, in the case of often, one of the challenges we know, there's lots of challenges of mental health nationally and in rural specifically, but one of them is if I park my car in front of the mental health provider in town that's on the street, people are going to drive by and see that.
Yes.
And so how, these are all put under the broad base of access, and let alone the affordability question. Do I have health insurance? Can I afford my deductible?
Yeah.
All those kinds of components as well. So we need to be thinking about all of these. Some of them are more important for others. And as we see what's generally forecast to be a decline in health insurance coverage over the next few years, that's certainly going to affect access, and it's going to be concentrated among low-income adults who are going to be most affected by a lot of those provisions. But we also need to think about what can we do to help with that? So will we see an investment and expansion of community health centers and free clinics and hospital programs that are able to expand charity care? Again,
FQHCs, you name it.
It's hard it's hard to think about that as all this money is disappearing from rural health, and from the healthcare system in general. But that's going to be a real critical consideration moving forward, is understanding the multi-dimensions of access. And we'll start with, first and foremost for most people is that health insurance coverage, but it goes beyond that. I'm excited about a recognition started really by the HRSA, the Health Resources and Service Administration, in about 2018, I think is when it started, to invest in graduate medical education in rural and federally qualified health center communities. And their program is just a great example. Their program creates technical assistance and resources to a place that says, we kind of would love to train docs here, but we don't really know how to do it, and we can't afford the launch cost. And so grant program provided these across the country, created technical assistance centers to help them accelerate the approval process and go from what might have been 5 years now to 2.5 years, because they have the resources they can jump with. That kind of thing. There's an RMOMS grant out of HRSA that again leveraged what we've learned about innovative models for maternity care and recognizing access to maternal health and the limitations of that. So clearly, I think it's unequivocal that access will be challenged in many dimensions moving forward. what can we do broadly in the context of declining resources to figure out targeted interventions and programs that can help mitigate that gap?
Yeah. And if we can solve that,
Yeah.
right, you and I are going to we'll be crowned something. But access, what we grow weary about in rural is, as a declining reimbursement occurs in our industry, costs are going up, inflation, the demands, can you still provide those services? You and I both know. Look at the research you probably have already done in the areas of obstetrics that are closing across rural communities. It's happening at alarming rates. Just 30 miles down the road, an OB just closed at a hospital. Now I'm the only guy in town, right, in the Tri-County area. It's very, very concerning. And so access now becomes more complicated for patients who don't have transportation. So all to your points, we're going to have to study this closely, but then we're going to have solutions that can address this, like OB stabilization, like, how do we negotiate better with payers, including the government? 72% of my payer mix is the federal government and the state government through Medicaid and Medicare, but they don't negotiate with me. They're, we're price takers. This is what you're going to get. And so all of those things we'll keep an eye on. And that's another segment you and I should come back and address is access. So if you're open to that, we'll get you on the schedule for that one.
JJ, I'm always happy to hang out with you. And the maternity thing is a great another example there, because most hospitals lose money on maternity care, but they do it because it's important for the community. And so
that's right.
You can better afford to run that loss when you've got sufficient revenues to cover your costs in other directions. And as those get pinched and that 3% profit margin becomes a -1, it's harder to sustain that maternal. And so I think that's another downstream effect that we need to be watching carefully over the next few years.
Absolutely. Great observation. All right. We're going to wrap it up with, and I know we've exceeded our time today, and I apologize. You probably have students eagerly awaiting for you. Is it still the 5-minute rule? Like if you're not there in 5 minutes, they cancel class? Is that what it is?
That's right.
All right.
Exactly.
All right.
Yeah.
So hopefully you don't have a 1 o'clock. But so let's talk about healthcare staffing. Okay. There's a lot of conversation right now about physician shortage areas. A lot of issues about the shifting staff post-pandemic. What are you hearing? What are you seeing about healthcare staffing? And I know we could spend a whole nother episode on that, but as you talk about recruitment, you also have to talk about retention. People get into healthcare. There's, we're addressing violence in healthcare, patients that are coming in, violent towards healthcare leaders, they get out, healthcare workers, excuse me. So let's talk a little bit about that.
So, I have a good friend who likes to say that she's been studying health workforce for 25 years, and for 24 years, no one cared. There is this, right. I think it is we certainly learned the importance of thinking about health workforce during the pandemic. And maybe you had a ventilator and an ICU bed, but without a respiratory therapist, it was pretty, you couldn't use it. So I think there's been a lot more attention to health workforce. You mentioned workplace violence, I think, is certainly of a concern. So you're right. This is another thing that we could spend hours on. I think 3 that I would highlight. One I've already talked about, which is the federal and other investment in training primarily physicians, but I think that's expanding. Some dental initiatives as well, and I think that's going to continue to expand. The recognition that the highest predictor for working in a rural practice is where you trained in a rural practice. Well, that and did you grow up in a rural area? So those two.
Did you grow up?
Yeah,
right,
I can't change where you grew up. I can change where you're trained.
No. That is true.
So a recognition of that and the deliberate and strategic investment in training more professionals in rural settings so that they say, yeah, I hadn't thought about it, but I really like it out here. And this is where I'm going to, this is where I want to practice for the rest of my career. Second would be team-based and interprofessional care. That's especially important in rural areas and trying to better understand how we can deliver in a more efficient manner And sometimes when you say efficiency, that people think in productivity units, but in a way that the team can work with seamless handoff. And that may mean medical care and mental health and social needs, for example, through a social worker embedded in the clinic that addresses these social determinants of health concerns. So, and I already spoiled the third one there, and that is the role of social workers in our medical and healthcare in particular have been really leveraged the last few years, especially for engaging with social needs.
Absolutely. So we're seeing the shift. We're hopeful that we can encourage through programs like yours, you can raise the awareness of the critical nature of rural healthcare, because at the start of it all happens in the rural setting. Patients are brought to their local ER. Patients are then, if they're high acuity, having STEMIs, obviously they're transferred out to tertiary centers. But all care is local. It's what we say all the time. And so if we don't have those local providers, we are in a world of trouble because of the lack of transportation, the lack of the financial wherewithal for patients to travel hundreds of miles. And so we're going to look at these, what we call deserts, right? I think you're probably doing a lot of research on obstetrics deserts and, deserts in rural health. And we'll continue to study that. But it's been an absolute pleasure talking with you again, Dr. Holmes. It's always insightful. You're doing a lot of research, but you're also a voice for rural health. And I want to thank you for that, because you go into the classroom, you write your papers, you're giving editorials and podcast interviews like this with an eye towards saving rural health. And it's so important. God bless the fact that you come from Michigan and that you know some of the uniqueness of Michigan. But so goes Michigan, so goes the rest of our country, because we have a lot of rural states, a lot of rural counties in this nation, and we have to preserve what I feel is some of the most important medicine in healthcare, which is rural medicine. So I want to thank you for the work that you've done in the work at the college, but also just being that voice that we needed. So thank you, first of all.
And thanks for the work on this podcast and other things that you're doing, JJ, to help raise awareness across the state and country as well.
Thank you. And before we close, we're doing a segment called Rural Health Recommendation. And every guest that we have on the show, we ask them to contribute a recommendation. And it could just be some sage advice. It could be, here's what I would say to the next generation of healthcare leaders, what you should be watching for. It could just be to a new leader, not even in the C-suite, that just stepped up and decided to take on a management job, because folks listen to this podcast from many, many diverse areas of healthcare. So what would be your rural health recommendation to someone today if you could get before that leader to give them some sage advice?
This probably isn't really groundbreaking, but I would say that the rural community is small. And what I mean by that is there's no or little anonymity often. And so you have to think about that in all your interactions. I can sometimes be a terrible person when I'm waiting in line for coffee or bagels or whatever. And that works in Raleigh when I can be a little bit grumpy about the person who hasn't placed their order quickly. But it doesn't work in rural because 10 minutes later I'm going to run into them at work, and so
absolutely,
it makes. I think it's understated in the sense that living in a rural area makes you appreciate people more, and because you need to be kind, because this is not a one interaction road rage. I'm going to show you I'm upset with your slow merge,
absolutely,
because 10 minutes later I'm sitting in their room at the principal's office. So.
100% accurate. I can give you a live example every day from my life, whether it's going to the restaurant and having someone stop in and say something about their bill, their care, asking the waitress, what was he drinking? Was that an iced tea or was that a Long Island? That was a true story. This morning, I had a 7:00 meeting with my physicians, and I do a CEO coffee hour every month just to share information. And so I stop into the gas station to get my morning Monster drink, and I'm stopped by someone who absolutely unhappy with the ER services. And I always remind our physicians that in a small town, you're a celebrity whether you want to be or not. And I'm not even saying celebrity in the mindset like we think of Hollywood, but everybody knows you. They're watching every move, every action. It can be a benefit because, well, you are, and then it can be a detriment. And so you've got to live your life according to understanding that you are in this bubble. And so it's a great point, Dr. Holmes, because it's one that I always tell physicians. Just yesterday, when a new physician was interviewing, and I said, well, you don't have a lot of experience in rural. Let me tell you how it is. And, you go to the church with these folks, you can see them at Walmart, you're going to take care of them and their family. How you treat them is so critically important. So great sage advice. It's always a pleasure to talk to you. It's great to read the work that you're doing. But what a pleasure it is to learn some of these insightful things you've shared. So once again, thanks for joining us today on Rural Health.
Thanks, JJ. Anytime.
And thank you to our listeners for tuning into Rural Health today. Catch our next segment, Rural Health News, to stay up to date on the current state of rural health every Monday, wherever you get your podcasts. Don't forget to check out the latest updates and resources from Rural Health Today at ruralhealthtoday.com, and make sure you've subscribed to the show so you never miss an episode. Until next time, remember the power of rural.
Thank you for listening to another episode of Rural Health Today, the podcast where we connect you to what really matters in rural health. Rural Health Today is a production of Hillsdale Hospital in Hillsdale, Michigan, and a member of the Health Podcast Network. Our host is JJ Hodshire, our producer is Kirsten Newlon, and our audio engineer is Kenji Ulmer. Special thanks to our guests for sharing their expertise on the show, and also to the Hillsdale Hospital marketing team. If you want to submit a question for us to answer on the podcast or learn more about Rural Health Today, visit ruralhealthtoday.com.